division and the
Recording in
ability of those
progress.
cells to spread to distant organs. According to Globocan 2022, 20 million new cases and 9.7 million deaths were reported worldwide. Projected 2025 cases are 30.5 million, as India ranks third globally in new cancer cases with approximately 1.4 million new cases and 9,16,827 deaths reported. Madhya Pradesh is among the 5 states with the highest absolute cancer burden, reporting a rate of approximately 106.9 cases per 1 lakh people.
World Cancer Day is an annual global initiative held on February 4th to raise awareness, improve education, and catalyze action against the cancer epidemic. The theme of the World Cancer Day 2026 is United by Unique. It focuses on a personalized, people-centered approach to cancer care, acknowledging individual experiences while uniting globally against cancer. It aims at not just treating the disease, but adopting the perspectives and experiences of individuals, caregivers, families, and communities as participants. Cancer is more than just a medical diagnosis. It is a deeply personal matter. But hoping is how the impossible can be possible after all.
Now we would like to invite on stage our esteemed guest, Dr. Vinod Bhandari Sir, founder chairman and the visionary backbone of SAIMS.
Dr. Mahak Bhandari Sir, Pro-Chancellor and Head of Robotic Surgery.
Dr.
Jyoti Bindal Maam, Provost, Sri Aurobindo University.
Dr. A.K. Mishra Sir, Vice Chancellor and in charge of Cyclotron.
Dr. R.R. Vavare Sir, Dean, Sri Aurobindo Medical College and PG Institute.
Dr. Anand Mishra, Registrar of Sri Aurobindo Institute.
Dr. Jayshree Tapadia, Dean, Student Welfare.
To light the lamp. Thank you, everyone.
Thank you, everyone. Now I would like to invite on stage Dr. Mahak Bhandari Sir, Pro-Chancellor and Robotic and Laparoscopic Surgeon, to come on stage and say a few words about the achievement of his department as he has to leave for surgery. Then we will proceed with the program.
Lights.
Yeah, so good afternoon, everyone. Warm welcome to everyone on the World Cancer Day. And I welcome the chief guest, our chairman, Dr. Vinod Bhandari, and all the faculty members and all the departments pertaining to the cancer division. And I'm proudly saying that we are starting with the preventive oncology department in our hospital now. So I would just like to speak something about what all things we are doing in cancers pertaining to surgery. And because I'm a robotic GI surgeon, so I would just like to talk more on the role of robotics in the cancers for the surgery. So as I am Dr. Mahak Bhandari, I am a professor here and I am the consultant at Mohawk Bariatrics and the other hospitals of this group. So I have no disclosure, but I am a consultant to most of the major companies and I work with the other consultants as well. So the people who are from this place and the people who have been invited from some other place, this is our medical school and the IRCAD India Center and the Mohawk Bariatrics and Robotics Super Speciality Center. So I would like to talk some general things also, because I can see some students also here apart from the PGs, that what is robotic surgery and the department of robotic surgery, how it is there, how it is helpful in cancer prevention to do robotic surgeries in the cancers. So what is a robot? It is a instrument which is a programmable device which can do some complex actions automatically with the speed and the precision, in which the surgeon takes care of the control. So basically, robot is a machine, but it is being operated by a surgeon only. And the good part about robotics is it has got better vision, because there is a very good depth perception. Then there is clear communication, because you are in the OT, you are sitting in the console, and then you can talk to the your assistants and everyone with this particular medium. Because it's a robotic surgery, so you don't need bigger ports. There are smaller incisions, and it's just a 8mm incision, less than a centimeter, with better range of movement, because I'll just come to it later, because it is just like a human hand, how our wrist moves. I always say in my lectures that you can see me moving my wrist in just 180 degree or say less than 180 degree, but robotic is a pivot joint, so it can go up to 270 or 360 degree also. So you can imagine how well the robotic surgery can be useful for doing the cancer surgeries or any other surgery for that matter. So this is known as the dexterity, like multiple uses can be done by this particular movement. And then ergonomically beneficial, because now the systems have come in which you can stand and operate also. Normally in a robotic console, you have to sit, but now because some people like to stand and do the surgery, so you can stand and you can do the surgery also. This is one part which is known as the surgeon console. So for all the people who are here, the robotic console consists of a surgeon console, a patient cart, and a vision cart. Vision cart means where we see. Patient cart means which are the arms of the robot which are there inside the patient, and this is the surgeon console in which we can sit or we can stand. As you can see, there are two models. The screen can come up, so you can stand and you can operate, or you can sit down on a good relaxing chair, as you can see in some of the pics, and you can operate. So why robotic surgery for cancers? Because see, there are many complex procedures. You know, when you are doing cancer surgeries, there is a lot of vascularity in the organs, so there's a lot of bleeding. So because of the good dexterity of the robotic arm, you can do many complex procedures with ease. And because the robot is a machine, so you can think of, if there is a patient who is very like an obese patient, you can again do a surgery on that particular patient also by using the robotic platform. Then most important thing is that in a robot, you can control the camera by yourself. So when you'll see the robot doing the surgery, or I should not say the robot doing the surgery, when a surgeon is doing a robotic surgery, then the camera is also being controlled by the robotic surgeon himself. So you can just understand that inside the operating room, you're just seeing a surgeon, the assistant is just standing on the other side of the patient, and all the arms are being controlled. Even the camera arm is also being controlled by the robot. So some of the commonly used robotic system, this is a SSI Mantra made in India robot. Then there is a Versius robot, which is by the CMR, Cambridge Medical Resource Solution System Company, which is an open console. As you can see, all the arms, you can see a person who is holding the arms of the robot. Then this is the most important and the main system, which is the Da Vinci intuitive system. And I am very much thankful to the chairman, sir, that this is the only institute in the entire India, I must say, who has got all the robots, whichever is available in the world. So all the robots are available in our operating room. And this is by his vision only that we are able to operate. And I always say that this is I'm just telling you about the clinical things. I do play a managerial role in this particular institute, but because of making him work right now, I am able to do the complex surgeries by using the robot. So all the robots are available in our operating room also, and you can give the benefit to the patient. So as I was telling you that this is a just like a human hand. There's an endo wrist. You can just understand it can rotate, it can turn itself, it can do whatever things it whatever possible manner you can think of it can do. The robotic arm and the robotic instrument. So the good thing is how it processes. The movements are all scaled down. Then there is a good 3D effect. You get a 3D vision. It is just like you are sitting inside the cavity wherever you're operating, and you are doing, even if you're doing a nephrectomy or say you are doing a gastric cancer, you can just think of that you are sitting inside the abdomen and you are doing the surgery. So this is the processing of a robot. Challenges, yes. Some people may think that ethical challenges are there, that robot is operating, whereas the human is not operating. It is a robot and robotic arms which are operating. So yes, there are ethical issues. Then there's a steep learning curve because you have to be well versed in laparoscopy. Then only you can go for robotic surgery. It's a very expensive machine. A normal machine costs around 13 CR. So you can very well think of it's a very expensive machine, but for the patient benefit, we can very well use it. Then it's a very superior machine. So I'll come on this later. What all advantages now the robot has. So as I told you that there are 7 degrees of freedom, high resolution imaging and all. So key areas in which you do the surgeries are the gastrointestinal surgeries, the colorectal surgeries, as you must have commonly the gastric cancer or gastric obstruction. Then the colorectal, there is a small bowel or a large bowel cancer is there, or a prostate, commonly prostate cancer, gynecological cancers in which you do hysterectomies, head and neck cancers, or urology, kidney cancers, nephrectomies are being done, and then the lung cancer or the thoracic cancer. So everything, everywhere the robot can be used. So how we started the robotic program in our institute. I have trained each and every staff of our institute in the operating room to run a robot. So this is a small video. You must not be hearing the sound, but at least you can see the video. So you can see that I am teaching each and every basic, how to put the ports, how to maneuver the arm, each and everything. I have made these small videos for my operating OT staff, how to use the robot, how the arms look like, so that when they enter the operating room, they should not feel that ये कौन सी machine आ गई, कैसे इसको run करना है. So you can see that I taught them each and everything. Then I made them put the ports only. You do it. And I was just standing there, just they'll make mistakes, but you have to teach them. So this is how we started the robotic program in our institute. And I have made these small videos so that, and I have taught each and every basics of the instrument also. As you can see, I'm telling them how to increase the height, how to decrease the height, what is the mean of this green bar, how the instrument will maneuver. So everything has been taught, and that's how the robotic program has been started in this particular institute. I'm just showing you a small video as to how the arms move. As you can just see, there was a gastric cancer in this particular patient. So you can see the movement, how that the camera, I'm moving, instruments, I am moving. There is no one in the OR. I am the only one who is operating on the patient. I mean, the surgeon is operating on the patient and we are doing, and you can just see how beautifully the robot works. And you can very well understand that. I'll just run through because I'm taking a lot of time. So as you can see the suturing and all, I'll just show you because these are the many important things. You can see how any movement, like you want to go right, left, any degree of freedom you get in the robotic system and the robotic console, and you can attempt a surgery by doing this. You can see how beautifully you can catch hold of it. And truly speaking, the vision you are seeing here, the vision which the surgeon sees in the console is far more better. So you can very well understand that how beautifully the surgery can be done by using the robotic platform. So I'll just run through. Now it's the era of telerobotic surgery. It means that a person is sitting somewhere and the surgery is getting happening somewhere. So like if I'm sitting in Indore and I'm getting the surgery done somewhere else, so now it is very much possible that remotely you can sit and you can operate the patient so that you can give your services as a robotic surgeon to those parts of the country where the robotic surgeons are not available, or where the people need robotic surgery, but there is no one to do the robotics there. So as you can see that I was sitting in a, I'm just showing you an example that I was sitting in a IRCAD India training center, and the operating room was there at Mohak, and I was operating sitting there. So because of this tele-robotic surgery, this is a bridging between the rural and the urban areas, and reduced travel time. We can sit here, we can operate anywhere. Just the training has to be there, and now this is the future. Then again, I'm just telling you what all things have come in the robotics, so you can very well think of that these are the things which is there now, present there. Now you can do the surgery sitting in a bus also. You take the bus somewhere, and the surgery is happening somewhere in the other part of the world. You can operate inside by sitting inside the bus only. So this is a pic. I had demonstrated a case to some Irani delegates in which the patient was somewhere abroad and we operated from the bus. You can see the bus standing just near the hotel only, and I was sitting inside, and these are the Irani delegates who were just watching us how the surgery was happening. This was the bus where the robotic platform was mounted. One more thing now which has come up, that you can take the robotic surgeon console in your office and you can do the surgery. So you can very well think of that what will be the future now, like sitting in your office and doing a surgery there somewhere else in any part of the world. So these are some of the pics of how the future would be there. So thank you for a patient hearing. And I'm open to any questions if anybody want to ask any questions regarding robotics, because it's a very, very interesting topic. Thank you very much. Or else we can start the other presentations.
Thank you, sir.
Thank you for the presentation, sir. Now I would like to invite Dr. Dilip Acharya, sir, Adjunct Professor, SAIMS, to come on stage and say a few words on UICC World Cancer Day and prevention and early detection of cancer.
Good afternoon, everybody. At the very outset, I'd like to congratulate and thank the founder chairman, Dr. Vinod Bhandari, because his initiatives in prevention of cancer, the early detection of cancer, the 3 buses here, and an announcement for his preventive oncology department. I'm sure it will be saving a lot of lives in future. And definitely it will reduce the mortality and the morbidity also of the cancer also. UICC, we are gathered together to celebrate or observe the World Cancer Day. UICC was founded in 1933 with headquarters in Geneva. It is the oldest and the largest global membership organization dedicated to reducing the global cancer burden. Apart from World Cancer Day, UICC has been instrumental in designing and writing the TNM staging system, which we all have learned during our even MBBS and MS also. And the major event they convene is World Cancer Congress. Every 2 years, I've attended 2 of them in Malaysia and China also, and the World Cancer Leaders Summit also. So the theme this year is United by Unique, which places people at the center of care, explores new ways of making a difference. Few days ago only, Dr. Ajay Kumar was here. He was also talking about the patient-centric treatment. So cancer, we all know cancer is more than just a medical diagnosis. It's a deeply personal matter. Behind every diagnosis, like a unique human story. Stories of grief, pain, healing, resilience, love, and more also. The theme says everyone has unique needs, unique perspectives, unique story to tell. Yet people touched by cancer are united in a shared ambition to lower their sufferings, the cancer burden. That's why World Cancer Day counts on everyone. Patients, loved ones, caregivers, friends, neighbors, doctors, practitioners, researchers, each and everybody. Well, the World Cancer Day, and I'm a member of UICC, I see that they start working on it almost 4 to 5 months before the day comes. They keep on sending every member so many documents, also emails, also they arrange meetings, also webinars, also that. Because this shows that the impact of World Cancer Day 2025 was 6 billion impressions, 9 million free engagements. So the whole world is getting involved with almost 1,120 members organizations across the world with 172 countries involved. So coming to the main part of the prevention early detection, there are two most powerful strategies to reduce cancer deaths. Experts estimate that nearly 50% of cancers can be prevented and detected early because of change of lifestyle, awareness, and timely screening. Prevention focuses on reducing risk factors that contribute to cancer development. The lifestyle, 2 or 3 points I'll straightly touch about. First and foremost is avoiding tobacco. It is linked to at least 20 different types of cancers and responsible for 22 to 30% of cancer deaths around the world. In India, we all know India is the global capital, so to say, of oral cancers, just because of the habit of chewing tobacco in our thing. The next is lifestyle choices, obesity, excess body fat. At least 13 types of cancers are directly involved because of this. The mechanism is that fat cells produce excess of estrogen and inflammatory proteins, which can lead to uncontrolled cell division. So diet, physical activity can lead to weight management, and that will reduce the obesity. The third important thing is lifestyle choices like alcohol, which is again a group 1 carcinogen. It is linked to again 7 main types of breast cancer like breast cancer, colorectal, liver, mouth, pharynx, larynx, and esophagus. The multiplicative risk is there because the people have the habit of एक हाथ में अगर glass है तो दूसरे हाथ में उनके जो है cigarette रहेगी. That means a combination of alcohol and tobacco or smoking increases the risk multifold also, and 30 times higher risk of oral and throat cancers because of this. Diet, again, maintaining a healthy rich diet in fruit, vegetables, and whole grains is preventive. Environmental protection there, vaccination, we all know. There's a lot of stress by the government also for cervical cancer vaccine between the age of 9 to 14. IMA has been requesting government to include it in the immunization schedule, and probably it will be done soon. Then why early detection saves lives? Because treatment is effective, lower treatment cost is there, the quality of life improves, and the population impact is also there. But in India, we still get patients coming to us, almost 60 to 70% patients coming to us in late stages with limited screening access. Now, but in Indore and around, rather in whole of MP, the buses of Aurobindo are going for screening only. And in times to come, definitely it will show an impact there. And the myths are always there. People still come to and ask us, "Sab operation karenge to tumor fail jayega kya?" So the myth is always there. We have to tell them, inform them what details about. Looking at this slide, it will show breast cancer, if you diagnose it in stage 1, the 5-year survival rate is nearly 99%, falls down to just 22% in stage 4. Similarly, cervical cancer from 92% treatment, stage 1 diagnosis and treatment, falls to 17% in stage 4 if diagnosed and treated there. So that will almost all cancer cases, if they are diagnosed in stage 1, early stage, we are able to give them a good remission also, good treatment, curative also. But if they diagnose them late, which is normally happening in our country, and the overall survival goes down. So the power of early detection is to catch it before it starts, to identify precancerous lesions like in oral cancers, we have leukoplakia, erythroplakia, submucous fibrosis, but this can lead to this if not treated in time. Similarly, CS cervix, which can be done by VI alone, can lead to a fungating mass if not treated and diagnosed earlier. We all know about the warning signs: change in bowel habits, sore throats, unusual bleeding, lump, indication of difficulty swelling, obvious changes, nagging hoarse or same. All these can be a normal symptom also, but can be a symptom of cancer also. So we have to be extra careful about it. And the power of early detection, we only see the screening is the search for cancer in people without symptoms. For breast, we have a mammogram, a cervical lesion, regular pap smears and HPV test, colorectal colonoscopies, lung में low dose CT scans are there. Prostate, we have serum PSAs, oral cancer, self-examination, clinical examination. They can all help in early diagnosis. Now liquid biopsy is also coming up in a big way. That will help in early diagnosis also. To conclude, I would like to say one should have a prevention plan of lifestyle modifications, that is no tobacco, no or moderate alcohol, and no obesity. Get vaccinated for HPV and hepatitis B. Stay active at least 150 minutes of moderate activity per week. Then eat smart. Prioritize fruit, vegetables, whole grains while limiting red and processed meats. Schedule checkups, which is very important. And then genetic testing also, like in breast cancer, because I had seen when I was in US for 20 years back, they were doing genetic testing and going for prophylactic bilateral mastectomies also. That is, getting the breast removed before a patient developed a cancer, because the patient had a genetic BRCA1, BRCA2 positivity with relatives also BRCA positive, like that way only. So here I'd like to conclude that now Aurobindo is soon going to, Dr. Vinod already announced that we are going to start with the preventive oncology also. So the Aurobindo can become a comprehensive cancer treatment center, because we already have a preventive now, then all medical, surgical, radiological the innovations and the treatment centers, along with palliative care also. So I'm sure in times to come, Aurobindo will be a very major center for cancer control. Thank you very much.
Thank you, sir. Now I would like to invite Dr. Vinod Bhandari Sir, Founder Chairman, to come on stage and say a few words regarding SAIMS' contribution in cancer control, its journey so far and beyond.
All faculty members, बाकी सबका नाम नहीं ले सकता, बट एक गेस्ट आज अपने वहाँ हैं, प्रोफेसर सूद सर हैं. ही इज प्रोफेसर ऑफ न्यूक्लियर मेडिसिन प्रीवियसली इन पीजीआई चंडीगढ़. आज ही उन्होंने ज्वाइन किया है, तो वी ऑल वेलकम हिम. आज विश्व कैंसर दिवस है, और यहाँ आप लोगों को लग रहा होगा मैंने आप सबको क्यों यहाँ इकट्ठा कर लिया, स्पेशली बच्चों को, पोस्ट ग्रेजुएट को, इंटर्न्स को. फैकल्टी ने तो बहुत बार यहाँ सुना हुआ है. इसलिए क्या है कि हम लोगों ने पिछले 20 साल में और स्पेशली 15 साल में जितना भी कैंसर के लिए प्रिवेंशन पे और अर्ली डिटेक्शन पे काम किया है, और जितने डिपार्टमेंट बनाए हैं और जितनी हाईएस्ट टेक्नोलॉजी लाने की कोशिश की है, वो मुझे ऐसा लगता था हमेशा कि हमारे यहाँ के स्टूडेंट्स को नहीं मालूम रहता है, हमारे यहाँ के पोस्ट ग्रेजुएट को कितने को ही नहीं मालूम रहता है. एंड आई कैन से फ्यू फैकल्टीज ऑल्सो माइट नॉट बी नोइंग इट. इसीलिए आज ये प्रोग्राम रखा है कि हर डिपार्टमेंट वाला अपनी क्या क्या कर रहे हैं, कितनी इक्विपमेंट्स हैं, क्या इक्विपमेंट के फ़ायदे हैं और किस तरह इसका उपयोग किया जाए. इसीलिए आज ये मैंने प्रोग्राम ऑर्गेनाइज किया है, और कुछ नई चीज़ें डेवलप करें, इसके लिए भी आज अपन वो करेंगे. मेरा आप सबसे एक ही अनुरोध है और एक इच्छा है मेरी कि आप जितने भी हैं वो यहाँ के ब्रांड एम्बेसडर रहेंगे. ये जो अपन अर्ली डिटेक्शन का काम कर रहे हैं और देन बेस्ट ट्रीटमेंट देने का काम कर रहे हैं, इसको कंटिन्यू रखें. और सेकंड पार्ट ये है कि रिसर्च जितनी अच्छी से अच्छी कर सकें, नॉट ओनली कैंसर पे, बट अभी कैंसर का आज वर्ल्ड कैंसर डे है, तो मैं कैंसर के लिए बोलूँगा अपने पास हर सुविधा उपलब्ध है जो वर्ल्ड के किसी भी कोने पे मिल सकती है फॉर पेशेंट पॉइंट ऑफ व्यू. बिकॉज जेनेटिक टेस्टिंग हो जाती है, हमारे पास न्यूक्लियर मेडिसिन का डिपार्टमेंट, डॉक्टर ए.के. मिश्रा हैं, महापात्रा सर हैं, अब सर भी ज्वाइन हो गए अपने साथ, सूद सर भी, और साइक्लोट्रॉन भी डाल लिया है. तो नए नए आइसोटोप बना रहे हैं, नई नई चीज़ें बन रही है, नए ट्रीटमेंट्स आ गए हैं, रोबोटिक सर्जरी है. आप लोग भी अपने आप को इतना डेवलप कर लें कि हम कहीं भी दुनिया से पीछे ना रहें, और जितनी रिसर्च कर सकते हैं करो. हमें बहुत अपॉर्चुनिटी है. और एक बात ध्यान रखना कि किसी भी गरीब अनअफोर्डेबल पेशेंट को जाने मत देना. ये इंस्टीट्यूशन हमेशा तैयार रहती है, तो उसके लिए आप सब मेरे को साथ देंगे ऐसा मैं सोचता हूँ. और बाकी अभी प्रेजेंटेशन आप देखोगे तो आपको कई चीज़ें ऐसी मालूम पड़ेगी कि जो हमारे इंस्टीट्यूशन ने की है और उसका क्या क्या फ़ायदा हुआ है. हमने जो प्रिवेंशन पे काम किया है उसके रिजल्ट भी आपको देखने को मिले हैं हमें, तो हम और इसको एग्रेसिवली काम कर सकें, इसीलिए आज आप सबको इकट्ठा किया है, और आप सबका मेरे को सहयोग चाहिए था. थैंक यू.
Thank you, sir, for being the visionary backbone that you are.
Now we'll move on to our next session, Introduction to Oncology as an Integrated Science. Having cancer is not a death sentence. It is possible to live and thrive with a cancer diagnosis, including advanced stage cancer. Advanced cancer treatments focus on precision and personalization, moving beyond traditional methods for better outcomes, fewer side effects, and improved quality of life. At Sri Aurobindo Institute of Medical Sciences, we have the latest cutting-edge technologies and treatment options available for the best treatment of patients, including chemotherapy, immunotherapy, targeted therapy, bone marrow transplant, advanced radiation techniques like IMRT, IGRT, VMAT, SBRT, brachytherapy, advanced surgery options including robotic surgery, and diagnostic and therapeutic nuclear medicine department.
A multidisciplinary approach in cancer management utilizes a team of specialists from various fields to create a tailored management treatment plan through regular and collaborative tumor boards. Consider too, a ready-made cloth versus tailored. It's better when it's customized and tailored to the person, depending on the clinical, pathological, radiological extent of the disease and the choice of a patient. A bespoke plan is then formed, making it united by unique. I would like to invite on stage the heads of representatives from various departments involved in the integrated care to say a few words and their individual roles in oncology. I would like to request them to keep it within 3 to 5 minutes since we are time bound. Now I would like to invite Dr. Vinod Bhandari Sir, Professor and Head of Department of Radiation Oncology, to come on stage and say a few words about the achievements of the department.
Thank you. I'll say a few words about the Department of Radiation Oncology, when it was started, and how did it work and flourish the Department of Oncology in Aurobindo. So I joined this hospital as a full-time consultant in February 2005 and started the Department of Oncology at first. In initial days, only chemotherapy was given because there were no equipment for radiation that time. Then we started the Department of Radiation Oncology with the vision of Dr. Vinod Bhandari Sir in 2009, and the first high-tech linear accelerator of the state, the Clinic DMX with image-guided facility, was installed, and we started treatment on 16th of September 2010. The first patient was our own senior doctor and teacher of our founder chairman, myself. We inaugurated the department and then received the treatment for the first time. Till now, we have radiated about more than 12,000 patients. And we are at present, we are treating around 130 patients per day on the 2 linear accelerators which we have. In August 2003, because the patient load was increasing and our 1 unit was getting older, so we added another high-tech linear accelerator, the Halcyon Elite, in the department. We are able to do all sorts of radiotherapy with image guidance and 99.9% accuracy in dose delivery. We are able to do SBRT, SRS, IGRT, IMRT, voluntary DIBH, lattice therapy, and all. In this, we do a 3D image reconstruction of all the organs on the CT scan images for organ delineation, target delineation for radiation delivery. And we can do 2D and 3D image matching such that we can have an accurate dose delivery to the tumor and saving all the normal structures around close by to the tumor, such that the radiation side effects are much less. We are also doing SBRT, even tumors of around 1 to 2 centimeters size. We can target them accurately and give them 100% dose and reduce the doses to the normal organs to very low as seen in the DVH. We can do voluntary DIBH also. We have treated many patients on this voluntary DIBH, wherein the patient holds the breath, and then especially in left-sided breast cancer, we treat the breast such that the breast gets the radiation and the lungs and the heart doesn't get radiation a lot. They are very much minimized to reduce the side effects. We are also doing total body radiation, especially in bone marrow transplant cases and other cases. And we are doing this on our Halcyon unit. We are also doing lattice therapy, wherein we can target advanced tumors for better palliation. We are also doing adaptive radiotherapy, such that during the course of radiation, when the tumor shrinks, the size of the tumor shrinks and the normal structures may come in the way. So we read CT scan and contour the things and then treat the patient such that the tumor gets the dose and the normal structures are again saved. So these are all the latest technologies which are available in the world, which we are doing at our center. We are also doing extracorporeal radiation along with orthopedic department, wherein they remove the bone from the operating room, they send the bone to the radiation department. We radiate the bone, and then that is again reimplanted such that auto rejection is not there. We are the only center probably doing brachytherapy, all sorts of brachytherapy in the central India. We added the new brachytherapy unit in 2012, and this is the only center in MP doing all forms of brachytherapy. We have till now treated more than 1,000 patients with brachytherapy, and we are doing around 7 to 8 brachytherapy procedures every week. We are doing surface molds, interstitial, intraluminal, intracavity, intravaginal brachytherapy. These are surface mold patients wherein we can have an organ saving thing. We have saved the nose, otherwise it would have been chopped off. We are doing organ saving in breast cancers, in eyelid cancers, and intracavity radiation. Everything we are doing at our center. We have a big team now. We started myself alone. Now we have 4 consultants in the department. We started the postgraduate degree program in 2012. Until now, more than 60 students have been given postgraduate degree in MD degree. 20 students have studied further doing the DM and DNB. And the 3 students are working overseas, and 2 have started their own radiotherapy center, one in Lucknow and another in Panipat. We have more than 100 publications in various national and international journals from the department. We organize various state and zonal conferences. We are regularly organizing a classroom teaching course in radiobiology and medical physics, the subjects which are never taught anywhere other in medical science, which is attended by postgraduates from all over India. Our students have received many best paper awards in various state and national conferences, and our faculties have also received national and international awards and fellowships. Thank you.
Thank you so much, sir.
Thank you, sir. Now, I would like to invite Dr. Rajesh Padida Sir, Professor and Head of the Department of Medical Oncology, to come on stage and say a few words about the achievements of the department.
गुड आफ्टरनून। मैं मेरे डिपार्टमेंट का इंट्रोडक्शन दूं उससे पहले मैं बताता हूं कि जब मैं एमडी कर रहा था तो मुझे नहीं पता था कि इतने तरह के कैंसर होते हैं, और बाद में पता चला कैंसर नहीं, इतने तरह के कैंसर के डॉक्टरों की जरूरत पड़ती है कैंसर ट्रीट करने के लिए। फिर पता चला इतने तरह की टेक्नोलॉजी की जरूरत है, और फॉर्चुनेटली वी हैव ऑल टाइप्स ऑफ डिपार्टमेंट्स, ऑल टाइप्स ऑफ इंफ्रास्ट्रक्चर। अरविंदो में सब चीजें हैं, और ये करोड़ों रुपए के प्रोजेक्ट्स हैं। और हमारे इंस्टीट्यूट की खास बात यह है कि ये सब सुविधाएं गरीब से गरीब व्यक्ति को आयुष्मान में फ्री में मिली। तो दिस इज द ओनली डिपार्टमेंट वेयर वी आर एबल टू गिव बेस्ट टू बेस्ट फैसिलिटी, बेस्ट टू बेस्ट ट्रीटमेंट टू द पुअरेस्ट ऑफ द पुअर पीपल। नाउ आई विल बी एक और चीज बता रहा हूँ, मुझसे पहले और मेरे बाद जो भी आपको डिपार्टमेंट का इंट्रोडक्शन दे रहे हैं वो बस हमने किताब से कॉपी करके नहीं लाए, नहीं कोई पब्लिकेशन से लेके आए। हम वही डिस्कस कर रहे हैं जो हम करते हैं, जो अरविंदो में होता है और हर डिपार्टमेंट कर रहा है। So I will be introducing my department, Department of Medical Oncology. So what is a medical oncologist? These are special doctors which treat cancer patient with the help of chemotherapy, immunotherapy, targeted therapy, hormone therapy and biological therapies. So हमारा डिपार्टमेंट 2014 में स्टार्ट हुआ था। This was the first department. ये पहला डिपार्टमेंट था राजस्थान, मध्य प्रदेश और गुजरात में जो प्राइवेट इंस्टीट्यूट में स्टार्ट हुआ था। और मध्य प्रदेश, छत्तीसगढ़ में भी अभी एक ही डिपार्टमेंट इंस्टीट्यूट है जहां पे मेडिकल ऑन्कोलॉजी रन होता है। और उसके बाद वी हैव स्टार्टेड हीमेटो ऑन्कोलॉजी एंड पीडियाट्रिक ऑन्कोलॉजी। हम उसके बाद हमारे ऑन्कोलॉजिस्ट नर्सेस को ट्रेन करते गए, और हमारी पीजी सीट 2 से अभी वी हैव 6 पीजी सीट्स पर ईयर। वी हैव वेरी ब्यूटीफुल पीडियाट्रिक ऑन्कोलॉजी वार्ड, एंड दिस इज हार्ट ऑफ आवर डिपार्टमेंट। यहाँ पे हम बच्चों का ALL, AML, लिम्फोमा और डिफरेंट टाइप्स ऑफ सॉलिड ट्यूमर्स वी ट्रीट हियर लाइक विम्स ट्यूमर, न्यूरोब्लास्टोमा, रेटिनोब्लास्टोमा, हेपेटोब्लास्टोमा एंड मेनी अदर रेयर मैलिग्नेंसीज। सो दिस इज हाउ वी सेलिब्रेट आवर चिल्ड्रंस बर्थडे। सो जब भी बच्चों का बर्थडे होता है तो हम डिपार्टमेंट में हर महीने बर्थडे सेलिब्रेट होता है हमारे पीडियाट्रिक ऑन्कोलॉजी डिपार्टमेंट में। एंड वी हैव very developed blood and bone marrow transplant unit. We have 2 rooms for bone marrow transplant. Initially we were not having HEPA filtered unit, but now since 2021 we have HEPA filtered double room transplantation facility Here we routinely do fumigation, surveillance, cultures, irradiation of blood products, and granulocyte infusions. Till now, we have done 39 bone marrow transplant, both autologous and allogenic. And we have done bone marrow transplant from 3-year-old child to 65 years old child also. We have done bone marrow transplant other than malignancies also, like SLE and aplastic anemia. We have daycare facilities where we give chemotherapy, targeted therapy, immunotherapy. We do bone marrow aspiration biopsy there. We give intrathecal chemotherapies and minor surgical procedures we do there. We have a special biosafety cabinet where we prepare chemotherapy in a biosafety cabinet. This is very important. Tumor board. Tumor board मतलब क्या? हम सब तरह के डॉक्टर जो रेडिएशन, मेडिकल, सर्जिकल, पैथोलॉजिस्ट, रेडियोलॉजिस्ट, न्यूक्लियर मेडिसिन, सब तरह के डॉक्टर एक साथ बैठ के एक पेशेंट के बारे में चर्चा करते हैं कि इस पेशेंट का कैंसर का इलाज बेस्ट पॉसिबल वे में कैसे होता है. तो हम हर फ्राइडे को हमारे इंस्टीट्यूट में ट्यूमर बोर्ड रखते हैं और चैलेंजिंग केस डिस्कस करते हैं, एंड देन वी डिसाइड व्हाट इज द बेस्ट पॉसिबल ट्रीटमेंट फॉर दिस पेशेंट. We have all cutting edge diagnostic workup, especially in Department of Pathology. Here we do next generation sequencing, flow cytometry, cytogenetics, karyotyping, immunohistochemistry, MSI, bone marrow biopsy, and also other genetic workups. We do participate in clinical trial. हर नई थेरेपी के लिए, especially cancer में, clinical trial is a base. So we are participating in clinical trial. We have participated in phase 3 clinical trial for immunotherapy, that is nivolumab, and also in sickle cell anemia, one investigational drug we have participated. So, and in 2023, we got the prestigious Best Oncology Department Award by the 49th ICON Conference. And every year, our students do participate in the national and international conferences, and we get awards in many conferences. Thank you.
Thank you, sir. Now I would like to invite Dr. Ajay Sharma, sir, Associate Professor, Department of Surgical Oncology, to come on stage and say a few words about the achievements of the department.
Good afternoon, everyone. First of all, I would like to thank our founder, Chairman Sir, for giving me this opportunity to bring the work done by Surgical Oncology Department to this august platform. As a surgical oncologist, we have different roles in the management of solid organ malignancies. It can be in the form of primary treatment, diagnostic and staging workup, or a multimodality integration, as Sir already told, as a part of multidisciplinary board meetings. And then metastatic palliative settings to make the patients, terminal patients, cancer patients' life easier. We intervene with surgical procedures. So regarding evolution of surgical oncology, from radical resections, now we have moved on to organ preservation and precise surgeries. And there's a lot of advancement on the field of minimal invasive surgeries, as Mahak Sir already told about laparoscopic and robotic assisted surgery. Now, robotic surgery is coming up. So, Department of Surgical Oncology, it was started in 2012. Currently, it is working under guidance of Dr. Mahak Bhandari, our HOD, and 4 other consultants. We have 4 MCH PG seats. So, currently there are 12 senior residents. Since 2012, 4 residents every year are completing their MCH here. So departmental contributions, since from head to toe, whatever solid organ malignancies are there, Department of Surgical Oncology will be involved in the comprehensive care along with the help of Department of Radiation and Medical Oncology. So regarding departmental statistics, last year's data about OPD attendance was around 30,000 patients have attended our OPD. Approx 3,000 were admitted as inpatient department. And then around 2,500 surgeries, including major and minor procedures, were done. The beautiful thing, more important thing about department statistics is mortality rate of around only 0.6% in last year. So this is the different types of surgeries during last 3 years, what we have done. So mostly head and neck, as we all know, head and neck is the most common malignancy in our state. So most of the work is done around on head and neck cancers. Then rest of the surgeries, breast surgeries, gastrointestinal, urological, gynecological, musculoskeletal, and thoracic surgeries. So for the interest of the, I can see some students also MBBS students at the back. So for the interest of the students, I would like to show some of the pictures, intraoperative pictures of the surgeries that we carry out routinely in our department. This is a case of carcinoma left lower alveolus with floor of mouth involvement, which we have done a composite oncological resection with comprehensive neck dissection and a myocutaneous flap, pectoralis major muscle myocutaneous flap taken from the chest wall. This is a case of squamous cell carcinoma of the nose, where the nose was completely deformed by the tumor. So we have done a complete oncological resection with the nose reconstruction was done with the help of the forehead flap. The tissue was taken from the forehead of the patient, and the neck and the nose was restructured. This is another case of CA left buccal mucosa with huge skin involvement with fungatic nodal metastasis. This patient also underwent a composite oncological resection with comprehensive neck dissection, and anterodator thigh free flap was used for the reconstruction. So the specific specialty of this flap is that it is taken from the thigh of the patient, and then microvascular anastomosis is done at the site of the defect. This is again a case of CA tongue, carcinoma tongue, where patient has underwent hemiglossectomy along with neck dissection. The resected part of the tongue has been reconstructed with the help of a radial artery forearm free flap, which the skin and the vascular pedicle was taken from the forearm of the patient, and the reconstruction was carried out of the tongue in the oral cavity. So this again is a case of CA post-cricoid region and upper part of the cervical esophagus. So in the specimen, we can see whole of the larynx, pharynx, and the esophagus of the patient has been taken out. And for the feeding of the patient, we have made a tube out of the stomach of the patient, and that stomach tube has been brought into the neck and anastomosed to the remaining part of the oropharynx. This is another case of squamous cell carcinoma of scalp, which have been completely resected, and then a reconstruction has been done with the help of tissue taken from the thigh of the patient, that is ALT-free flap. So in the field of breast and thyroid cancers, we are routinely doing radical breast surgeries, breast conservation surgeries, oncoplastic surgeries, along with most recent sentinel lymph node biopsies and evaluation and management of thyroid cancers. So this was the case of some young 23-year-old lady, which she was having this growth on her right breast for a long time, but due to some social stigmas and lack of awareness, she was not able to attend she didn't come to the hospital. Finally, when she reached us, we did a surgery on her, and now she is completely healthy. This is another neglected patient. She has this tumor size of around, the weight of this tumor was around 10 kgs, as you can see on the weighing scale. She was she was almost bedridden because of this tumor, which we took out, and then patient was completely fine. This is the modified radical breast mastectomy surgery done for carcinoma breast. This is the sentinel lymph node biopsy photograph, in which when the early breast cancers, we use this technique to find out which nodes are involved in the cancer and which are not, so that we don't have to remove all the lymph nodes as we used to do in the initial days of this surgical oncology training. So this is another example of breast conservation surgery, where only the tumor part has been removed from the breast, and the breast reconstruction has been done using the nearby tissue of the breast. So this is a specimen. This is a case of carcinoma thyroid, where total thyroidectomy along with central compartment lymph node dissection has been done. So moving on to thoracic cancers, we are routinely doing laparoscopic thoracic surgeries, video-assisted thoracic surgeries, uniportal VATS, and robot-assisted thoracic surgeries for lung, esophagus, and mediastinal tumors. So this is a chest wall case of chest wall Ewing sarcoma, for which resection and reconstruction was done with the help of the mesh and the LD muscle flap. This is a case of around 20-year-old female with a huge mediastinal tumor. We can see on the right side of the chest, there was a huge mediastinal tumor, which was operated with midline sternotomy was done, and the tumor excised. And then at last, we can see the X-ray, post-operative X-ray of the patient with good expansion of the remnant lung. So this is again a picture of CA lung operated. This is a middle lobectomy has been done for the right lung. A case of cancer, lung carcinoma. Again, same lung carcinoma of upper and middle lobe, where lobectomy is done. So this is a case of CA esophagus, Patient underwent total esophagectomy with the help of video-assisted thoracic surgery, and then gastric pull-up was done, gastric conduit was made, and that remnant of the stomach was anastomosed to the remnant cervical esophagus in the neck. So in gastrointestinal hepatobiliary, again, we do most of the solid organ malignancies like gastric cancers. This is a specimen of oncological resection of D2 subtotal gastrectomy for the gastric cancer. Again, this is specimens of hemicolectomies, right and left hemicolectomies. This was a special case as huge biliary cyst adenoma. It's usually a benign swelling, but it was a huge occupying whole of the left and part of the right lobe of the liver, which was excised. Patient is completely healthy now. So this is the case of radical cholecystectomy has been done for carcinoma gallbladder. As Sir was discussing in the morning session itself, that carcinoma gallbladder is a very common cancer in our region. So this is how a radical cholecystectomy specimen looks like, along with the part of liver. You can see the gallbladder and the part of the liver resected. And lymph nodal resections is also to be done. So this was a case of 5-year-old child who was having hepatoblastoma, huge tumor in the liver, which medical oncologist has given the chemotherapy, and the tumor size has shrunk, and then we have done the resection of the remnant tumor. So this is the most favorite surgery of the GI surgeons, Whipple surgery done for the pancreatic malignancies, CVD malignancies, and duodenal malignancies. This is for rectal cancer. We have done APR with pelvic exentration. So for urological cancers also, we are doing routinely nephrectomies, partial, complete laparoscopic nephrectomy, germ cell tumors of the testes, and then gynecological cancers also, CA ovaries, hydroductive surgery along with HIPEC. HIPEC also we are doing. This is a short video of the HIPEC therapy being given to the patient intraoperatively. This is again a recent case we have done. The patient was having recurrent carcinoma ovary involving the pelvic deposit. There were a lot of pelvic deposits along with involvement of the rectum and spleen. So both rectum along with the recurrent disease and the spleen have been removed. This is again case of ovarian teratoma, and this primary ovarian malignancy with section with peritonectomy has been done for the patient. Musculoskeletal cancers also we are doing. This is a case of recurrent GCT proximal humerus, which underwent resection and then reconstruction with the help of a custom megaprosthesis. This is a soft tissue sarcoma, which has undergone surgery, and the patient is fine. So departmental academic contribution, we have published about articles in international and national journals, and multiple research projects are going on currently also. We have been presenting papers and posters in all the national, many national and regional conferences. So the message for World Cancer Day is, according to the theme United by the Unique, it emphasizes every cancer experience is personal, requires collective efforts to prioritize patient-centered care. And then every cancer journey matters. So let us unite to prevent, detect early, and ensure compassionate care to all of the patients. So thank you.
Thank you, sir, for the surgical insight. Now I would like to call Dr. Pankaj Sanghai, sir, Professor and Head of Department of Palliative Medicine, to come on stage and say a few words about the achievements of the department in palliative care.
Good afternoon, everyone. I'm here to give an overview of palliative medicine department. So I'm sure many of us may not be aware about palliative medicine. There's a common misconception about palliative care. It is termed as terminal care or care for patient who is dying. But it is more than that. It reduces suffering and enables the person and their family members to live well with cancer or any disease with a lot of suffering. So, and another misconception, people feel that once treatment stops, then palliative care starts. But it is not like that. It actually integrates the disease-directed treatment along with symptom management. So what basically we do? We manage pain with a very specialist approaches. As I said, it combines disease-directed treatment with symptom relief techniques. So like in cancers, we get a lot of mucositis after radiation or with chemotherapies. Pain is quite common with chemotherapies or radiations. We can reduce those suffering. I'm very proud of our skilled nursing services, which provide good nursing care, advanced wound management, colostomy care for these patients. Also, rehabilitation, psychotherapies, counselings are also part of it. And we provide a dedicated, compassionate end-of-life care for these patients. As a part of pain services, we have patient-controlled analgesia. I think that is not available in most of the institutes. What is the beauty of this device is it can give very specific medications to pain, to the patients with pain, and it can deliver the medications very safely. So today only we put a epidural catheter in the dorsal region for a patient with very severe pain, so that we can reduce the amount of opioid medications required, and it can be given only when patient is having pain. We titrate the opioid medications, and whenever required, we can switch between the opioids, because a lot of people think like only morphine is only choice, but whenever required, we can use other opioids also. Talking about our interventional pain management, we have techniques where a very minimally invasive, a small needle can give the pain relief at a targeted sites. Also, a concept of respite care. When a person is suffering a lot, we admit them for a short period. We give them aggressive symptom management, train family members, because they cannot stay in hospital for a very long time. So how to take care of those patients at home. And also this should be more affordable care, and that can be appropriate according to their resources. We have spoken a lot about what all technologies we have, but thanks to our chairman, sir, we have a services where care is our USP. We have compassion and empathy in our team members, so that we can take care of all patients regardless of their treatment status. I'm very proud to say that our center is a designated center for training in palliative care. We have been designated by ESMO, that is one of the largest body worldwide, and also CTC, which is run through AIMS and Singapore-based Lean Foundation. We are only specialist palliative care centers in Madhya Pradesh. So thank you. Thank you.
Thank you so much, sir.
Now I would like to invite Dr. Saili Kulkarni Ma'am, Professor, Department of Gynec Oncology, to come on stage and say a few words about the achievements of the department.
Good afternoon, everyone. If we talk about the achievement, the setting up of the gyne-onco unit was itself an achievement for us. So what is gynecological oncology? Specialized field of medicine which focuses on prevention, diagnosis, and treatment of cancers of reproductive organs, namely uterus, ovaries, cervix, vagina, and vulva. So our gyne-onco unit is fully functional since January 2022. Our center treats full spectrum of gynecological malignancies, from diagnosis to treatment and good follow-up. Care is led by specialist gyne-oncologists, and we are the only center in the central India offering comprehensive management of gynec cancers using minimally invasive surgery, that is laparoscopic as well as the robotic surgeries. And we also run a dedicated fellowship program in gyne-onco as well as minimally access surgery. So talking about comprehensive cancer care, if we talk about gynec cancers, it requires a multidisciplinary approach because we have young females who have not completed their fertility. So there is a team that is involved when we talk about gynec cancers, from the reproductive medicine to the anesthetist, pathologist, nutrition medicine, and then apart from chemo and radiation department. So it's always a comprehensive cancer care, and I'm proudly saying that we offer all these to our patients and to the poorest of the patients. So this is our gyne-onco unit organizational structure. The professor and head, Dr. Neeta Nathu Ma'am, with the unit head with the able leadership of Dr. Namrata Madam, And I'm myself Dr. Saili Kulkarni, and we have one associate professor and 2 assistant professors with us. Talking about our clinical workload since 2022, we have had over 10,000 of OPD patients with pap smear. These pap smears include our OPD as well as the pap smears that were the patients were screened in the bus, which went all over the villages. We have done 1,500 plus colposcopies, cervical biopsies, and the various endometrial and vulval biopsies. These are the pictures of the screening modalities that we all have and the treatment as well. The picture on the left is the pap smear or LBC, which is used for screening of cervical cancers in all the women. Then the picture here is about the thermal ablative technique, which we do at sea and treat. And the other one is of the hysteroscopic biopsies. So over years, we have treated more than 250 cancers, ovarian cancers, 100 plus endometrial cancers. And if you look, I want to bring your attention to the cervical cancers. Do you see in over 4 to 5 years, we have treated only 5 cervical cancers in our unit? That shows how much we are lacking in the cervical screening and even the awareness and prevention thing and the vaccination that we need to improve. We have achieved another milestone. We are the Central India's first robotic cancer center who performed cancer surgery successfully, and the program has been launched in our institute, strengthening advanced surgical oncology services with cutting-edge robotic technology. So this is our team, and great outcomes are never solo. They are symphonies of the teamwork. This is a beautiful team working in the OT. No sound. So this unit was inaugurated in 2022 with the vision of Bhandari Sir and Manjushri Madam. This is the super specialty OPD that is there in the cancer OPD block. This is our 98 number Gynae Onco OPD, where I will invite all of you, all the MBBS students, to come get aware about the cervical cancer and prevention by vaccinating yourselves with HPV vaccine. If you're not aware, please come. I'll be happy to help you out in creating awareness about HPV vaccine, not just for yourself, but for everyone. This is our OT performing laparoscopic oncosurgeries. The Gynae Onco ward that we have. Providing the comprehensive cancer care to all the patients. Thank you.
Thank you so much, ma'am.
Now I would like to invite Dr. G.N. Mahapatra Sir, Professor and Head of Department of Nuclear Medicine, to come on stage and say a few words regarding the achievements of the department.
Which one is it?
Good afternoon. I think I would like to tell you, since it's a World Cancer Day, so nuclear medicine, how helps you in cancer diagnosis and treatment. Since there are a lot of students here, so before I go into that, I would like to tell them what is nuclear medicine. May not be aware of this. So it's a painless procedure. We administer a radioisotope by IV, intravenous route, oral or breathing device by mouth. This radioactive material emits gamma rays and travels to the intended organ. Special gamma cameras, SPECT or PET-CT scanner or system interface with computer records these radioactivity in the form of image or the scans. then highly sophisticated computer tagged with the gamma camera or the PET scanner processes these data quantitatively, various recording data to diagnose and quantitate the extent of the disease process. So after you inject the radioisotope, there will be some waiting time. The patient may be asked to wait after the administration of the radioisotope. The waiting time varies from 15 minutes to 45 minutes to 2 hours, and in some non-cancerous cases, after 24 to 48 hours. This waiting time is necessary. Why? Because the compound, the radiolabeled compound, takes different amount of time to accumulate in the area of your body being studied. So after that time is over, then we ask the patient to lie down on the scanner, whether gamma camera or a PET, as a PET system. Patient is positioned next to a special detector of SPECT gamma camera or PET CT scanner, which will be placed very close to the part of the body being studied. Number of different pictures, images, which you gather, which you take. These images may be seen on the computer of SPECT gamma camera or a PET scanner, and it will be preserved on the film for a later study. SPECT, I just would like to inform to this house that SPECT gamma camera or PET scanner does not give radiation. Does not give radiation. It simply, what it does, picks up the signal from the radioactive compound injected. Even multiple pictures and the images will be taken, you will not be exposed to any sort of radiation. These pictures make it possible to gather more diagnostic information. What about after the test? You must be thinking, oh, once you come to the nuclear test and something will be injected, then you will be paralyzed. Daily activity generally not affected. One can resume his or her official daily routines immediately after the test. Regarding medication, yes, of course, certain drugs are to be stopped before the particular scan, such as mostly for renal, cardiac, and brain SPECT scans. So this is first in the list. This is a static thyroid scan. You can see here, there is a lateral caudal part of the right lobe of thyroid showing a cold area, and the left lobe is normal. This is enlarged with the lateral caudal aspect of there is a cold area. So the next step, one has to go for a FNAC, fine needle aspirate surgery, to find out whether the adenoma or a carcinoma. If carcinoma, what sort of carcinoma, what type of carcinoma. This is it is a cyst actually. This is where I belong to Mumbai. So this is, I think, the film star Dani Danjopa's scan. He came and did it, and we found a clear-cut cyst. So thyroid cancer is fairly a curable malignancy presented as a painless nodule in the neck as compared to the other malignancies. So what are the type of malignancies in thyroid? Papillary, follicular, they are the two varieties of differentiated type. Undifferentiated type is anaplastic. Then come the two rare carcinoma called medullary carcinoma. Good prognosis, medullary carcinoma, surgical resection like total thyroidectomy with central and lateral neck lymph node dissection does not respond to iodine-131 therapy as compared to differentiated cell CA thyroid like papillary, papillofollicular or follicular. So what should have done? It should be targeted therapies or external beam radiation therapy. Then comes the Hurthle cell carcinoma, a specific type of thyroid cancer composed of 75% of the oncolytic cells diagnosed by FNAC, either thyroid lobectomy or total thyroidectomy, and it spreads to bone, lymph nodes, or lung, and it is also not amenable to iodine-131 therapy. Now we'll come to the whole body bone scan. See, even if the PET and other things have come, but again, I'm telling you, bone scan is our bread and butter. So bone scan is very sensitive. So there are lots of other indications, but which will treat primary bone tumors such as osteosarcoma, Ewing sarcoma, or metastasis, osteoblastic metastasis in case of CA prostate and other things we can find it out. So this is a normal bone scan, how it looks. So a physiological distribution of the radio tracer in both skeletal system, central and appendicular skeleton. No other hot or cold area is seen. But here you can see here, there are lesions here. This is a CA prostate patient, osteoblastic lesions in the ribs in both sides. And this is another case patient. You can see there are a lot of other hot spot agents and also the pelvis area and the vertebrae, the scapulas and other things. So, and this is another case of lower 1/3 shaft of a right femur. There is a big growth which showing a increased uptake. So the doctors, they refer to us. We have to find out the localize the lesion as well as any secondaries anywhere or spread anywhere they are not. If it is localized, then they go for usually for amputation. Now we come to the iodine 131 MIBG whole body scintigraphy. It is a primary pheochromocytoma or neuroectodermal tumor, and it is very specific for pheochromocytoma. You can see here there is a big lesion in the adrenal showing is a kidney left side. Then we did a MIBG scan showing a of increased uptake on the upper pole, the same corresponding to the same area. Then F18 whole body PET CT. What we are doing it, we are very thankful and obliged to Professor Dr. Vinod Bhandari to give us the cyclotron, which we are getting us. We have started getting the more and more radioisotopes and more new tracers for research purposes, which will be done in the near future. I think my colleague who has joined today, Professor Dr. Dr. Sood, who has joined here today, so that we can do a lot of research work as well as regular work. So F18 FDG whole body PET CT is a useful procedure to diagnose, spread, stage, monitoring the response to chemotherapy or radiotherapy or surgical intervention. And as well as recurrence of residual disease, you can find it out. What are the cancers? CA breast, CA lung, CA head and neck, lymphomas, Hodgkin lymphoma, non-Hodgkin, B-cell lymphoma, CA colon, etc., etc. So here you can see that a big increased FDG uptake lesion seen in the left lower lobe, and it's a case of bronchogenic CA. So here you can see there is a lymphoma cases, so a lot of mediastinal lymph nodes involved, the superficial lymph node involved. So after you have the lymph node, so after the very good cycles of chemo, so you can compare here. Everything is clear. You can appreciate this. Everything is clear. So we can find the response of the treatment. Then this is another patient of the breast CA. Is a nodule. A nodule CT scan, increased FDG uptake, and the patient underwent radical mastectomy. So now comes the prostate cancer. Gallium-68 PSMA. We will be using soon, but we are now doing it F18 PSMA. And this typical World Cancer Day, today we are doing 15 F18 PSMA, which is the highest in whole of Madhya Pradesh. I am from Mumbai. I have never done 15 scan of PSMA for prostate in Mumbai also. Hardly 3, 4, 2, not like that. And therapeutic, okay. Then after detect the lesions, then what we do, we give a therapeutic agent, which we have started already, lutetium-177 PSMA, which you can inject, we can do it. It's a one-day procedure. We can get it and give it. And then, of course, 4 to 5 sittings are required, or minimum 4. So then the secondaries will be over. Then this is the third one is called actinium-225 tagged PSMA. So that is also will be coming. This is alpha therapy. Then comes the neuroendocrine tumor, gallium-68 dotatate, DOTA-NOC, and dotatate. So these are the target. These targets the somatostatin receptor (SSTR) So this can be used as a therapeutic agent like lutetium-177 dotatate or yttrium-90 dotatate or actinium-225 dotatate. Gallium-68 FAPI-18 fibroblast activation protein. This is acts on stroma, then uses in various cancers like sarcomas, breast, esophageal, lung, pancreatic. Therapeutic agents like yttrium-19, FAPI, lutetium-177, and etc. It binds to the fibroblast activation protein. Then amino acid transport, F18, FET, we can do. Then total whole body PET, we can do by copper 64 and copper 67. Then FES, that is called fluoroestradiol receptor imaging, which you can do it, which we will be having very soon in our cyclotron here. Then we can bind to the ER receptor. It provides a non-invasive whole body assessment of the ER expression, thereby assisting hormone therapy selection as well as identifying large regions of the biopsy. Then emerging trends, now we are moving forward to alpha emitters like actinium-225 and terbium-161, offering higher or more localized damage to the cancer cell. Concluding, diagnostic and therapeutic PET tracers in oncological condition, usually targeting with specific molecules with radiopharmaceuticals for imaging and therapeutic ablation. Theranostic, that is PET-CT imaging, is helpful for diagnosis status of target molecule in the tumor cell. It determines extension of disease that helps in clinical decision-making and design of effective treatment plan. Other advantages are assessment of biological behavior, tumor heterogeneity, prognostication of disease, predicting response, and toxicity of therapies. So now you see that we being in SAIMS, which you can see that these are the isotope PET tracer. We are already started doing it. So this is the F18 FET PET for the glioma, the brain, then FET, FES for the receptor, then PSMA, then sodium chloride for bone, as well as athermatous plaque, then gallium dotatate and dotaNAC. That is also be available. F18 DOPA for Parkinsonian disease thing, and ammonia study for the heart also. And FDG we are getting every time. These are the areas. With this, I conclude my things. Thank you.
Thank you, sir.
Now, I would like to invite Dr. A.K. Mishra Sir, Vice Chancellor in charge of cyclotron, to come on stage and say a few words on cyclotron and its importance.
Yes.
Good evening to everyone. Mr. Chairman, nation builder as well as social reformer, we are very grateful to you to really thinking about Madhya Pradesh. Reason behind is that who is having the vision to spend 100 crores of rupees in Ujjain to establish a center? And why to establish a center is very important for us. Reason behind is that everybody was talking about chemotherapy, radiotherapy, immunotherapy, surgery, and everything. If you don't see what you do, if you see, you can treat. Either you have to eradicate it, either you have to repair it by either methodology that you have been talking about. Methodology is yours, but what we try to do as a basic scientist to combine together to bridge the gap between the clinical science and basic science to see that how we can progress accordingly. So the VRM team, there are very small team with 4 people, so we are working together. We try to see that how we can develop the methodology. That methodology becomes the methodology of the Madhya Pradesh. We don't want to borrow the technology from the outside. Then we try to graduate further and we go for the preclinical studies, and finally you can see the images that you are going to see for the Parkinson, prostate, estrogen, any type of cancer, like one of our colleagues was talking about when he was doing his MD. He was not knowing that there are so many types of tumor. So here you have the 33 types of tumor. You can image by one universal molecule that will be developing this center in Ujjain. With this, I want to take you to the basic of this one, that what we do Everybody has studied in your 12th class, in your BSc, at the time when we were doing all type of this. So this is the cyclotron. It looks so beautiful. This machine is a really beautiful machine because this is the first in central India having 890 bed pressure. You can accelerate the particle of your choice and you can the molecules of your choice that you want to do. Why I have listed fluorine, oxygen, carbon, and nitrogen? Reason behind is that any medicine that you make, either you have hydrogen, either you have a nitrogen, either you have a carbon, or a heterocyclic compounds. You imagine, I don't say that the sky is the limit. I say that your imagination is limit. You tell me which medicine that you like to see. It should be leveled, and you would like to know that how much quantity it reaches to the site, and you want to take out the tumor, either you want to treat it. This we can design in central India very nicely by doing this PN reaction, either D-alpha reaction, any reaction you talk about, like Mahapatra Sir was saying that. We do a lot of sequencing, like we do in MRI, we write the sequence, how to do the synthesis, how we go about. And then yesterday we started working for this Cancer Day, started around 8 p.m. in the night. We finished today 10:30 in the morning to give you F-level PSMA, which is a peptide that you can do for the imaging. And that way today, what he was talking, that we have done 15 cases, and I have the compound to do 300 more cases, which is very record-breaking in entire country for the first time that we have made in Madhya Pradesh. Likewise, you look at this image, any surgeon, any physician, where to put the knife. The first image in the down, you see the second image just in the parallel, you see the third image. It's very easy for you to remove the tumor, and also you can see the viable tumor. You can look about this one, that the viable tumor, that very nicely you can put your knife and you can take it out. So you can really distinguish between necrotic lesion, viable tumor, either tumor that you want to really resect. So what I was saying, that nuclear medicine is the medicine of tomorrow, and you have the facilities that is created by Mr. Chairman in Ujjain that you can see and you can treat. This is what we want to say. And you can imagine that plethora that you have, you can go for SPECT, you can go for PET, you can go for therapy. And I promise you that in another 5 to 10 years, radiation targeted therapy is going to take over at the chemotherapy and radiation therapy in a very nice way. Now we are moving further, that you can talk about immunotherapy that we were talking, that we give the antibodies, we give the peptide, all kind of things you are doing to give the co-ligand, antagonist, whatever you talk about. Imagine, I take your antibodies, I put a beta negative, either alpha particle, I can treat very nicely in a very nice way. So with this, we are going to have a very good system at our center, and we are going to produce whatever you can imagine for treating the patient by seeing, not by just guessing. Like one of the slides you saw, that for the lymph node you have injected eosine, which is not very specific in nature. Here we can design very specific drug for visualizing as well as treating. And thank you very much for your kind attention.
Thank you very much, sir.
Now I would like to invite Dr. Devendra Nayak Sir, Professor of Department of Ortho-Oncology, to come on stage and say a few words about the achievements of the department.
So good afternoon, everyone. So today we are here for World Cancer Day, and I am introducing my department, Orthopedic Oncology. So we started our department in March 2022, and approximately 400 OPDs per year we are seeing since 2022. Surgical procedures we are doing, major surgeries, limb salvage surgeries, more than 100 per year we are doing, and minor more than 200 per year. So I am showing few of our achievements or few of rare cases we are doing here, and with the good results. So this is the case one, Ewing sarcoma of scapula. So we did the ECRT, extracorporeal radiotherapy, as already described by the Vinod Bhandari Sir.
we remove the entire scapula, do ECRT and reimplant it. And this is the post-operative 2-year follow-up of the patient. He is able to do all his activities. He is riding his bike and do all living activities. Another case of non-metastatic grade 3 chondrosarcoma proximal femur right. So the entire femur was removed and we did the total femur replacement. And this is the follow-up of patient at 6 months. And she is able to walk and she is perform her daily activities. Another case of osteosarcoma distal femur left. So we did ECRT in this patient again. We remove the involved bone, send it for the ECRT, we replace it, and this is the 6-month follow-up of this patient. She is able to even dance. This is the case for 12-year female non-metastatic Ewing sarcoma of distal fibula. The entire fibula is involved. So we removed the distal fibula, we did the mesh plasty, and this is the 2-year follow-up of that patient. She is now a kabaddi player. She is do all activity, jumping, running, everything. Osteosarcoma distal femur left with the subcentric lung nodules. We did it, wide local excision with distal femur megaprosthesis. This is the follow-up at 6 months. He is able to ride bicycle and he is able to do his all activities at home. He sent the video from his home. Ewing sarcoma, neck of femur right. So the entire proximal femur was removed and replaced. This is the post-operative. Another case, metastatic osteosarcoma, proximal tibia right with escape mets to non-metastatic lesion with escape mets to distal femur. So we did the composite megaprosthesis, the entire 30 centimeter of the joint along with the distal femur and the proximal tibia is removed. And this is the patient follow-up. And he is able to walk, the limb is salvaged. The non-metastatic osteosarcoma proximal humerus left. So this much of an entire big lesion was removed and replaced with the megaprosthesis. And now she is able to perform all activities. This is a 12-month follow-up. Giant cell tumor of elbow, where we did the total elbow replacement. The limb is salvaged. Spindle cell neoplasm of the distal radius ulna. This is the clinical picture. He was advised for amputation at so many centers. So we salvaged the limb. We removed the entire tumor, and this is the follow-up at 13 months. So in spite of that, we are doing so many other modalities also. We are using ECRT, cryosurgeries, 3D implantation, that includes everything. So now orthopedic oncology is a very established branch in our department of orthopedics. And I give special thanks to our chairman, sir, for promoting our orthopedic oncology department and our head of the department, Dr. Pradeep Chaudhary, sir, for supporting us. Thank you.
Thank you, sir.
Now I would like to invite Dr. Shweta Singh Ma'am to present a report of Nivaran Clinic and Ummido Wali Bus.
Good afternoon, Honorable Chief Guests, respected senior, my colleagues, and everyone attending this program. I am Dr. Shweta Vaskale, working as an Associate Professor in Department of General Surgery and working as a Consultant Surgeon in Nivaran Breast Clinic. So I would like to do the presentation on the Nivaran project and Ummido Wali Bus. So first I would like to introduce the dedicated family of doctors in the service of mankind. Dr. Vinod Bhandari Sir, Founder Chairman of the Aurobindo Institute, Mishra Bhandari Maam, Mahak Bhandari Sir, Dr. Shilpa Bhandari Maam, Dr. Mahak Bhandari Sir, and Dr. Shweta Bhandari Maam. Next, I would like to, tell most of the students are here, so I want you to know few things about the hospital. Our hospital is NABH accredited hospital and our lab is NABL accredited lab. We have 14-bedded multi-specialty hospital and most diversified ICU. We have 204 beds available in the ICU. Different ICUs are available at the institute: medicine ICU, surgical ICU, neonatal ICU, pediatric ICU, neurology ICU, then the CTVS ICU, critical care ICU, high-risk pregnancy ICU, nephrology ICU, and the GICU. Our institute is recognized by the Ayushman, ESIC, CGHS, RBSK, and other government-approved schemes are available here. State-of-art diagnostic facilities is available here. Now, we have 30 operation theaters and center for the robotic surgery and bariatric surgery. IRCAD India is also attached to our institute, then specialized in the congenital heart surgery, valve and bypass surgeries. Cochlear implant surgeries, then dedicated cancer hospital, as mentioned by the previous speakers. We have different departments: surgical oncology, medical oncology, radiation oncology, ortho-oncology, gynae-oncology, and breast clinic Nivaran. Surgery for the infertility and other surgical procedures are available here. We specialize work in the neurology and neurosurgery and sports physiotherapy. We have rehabilitation center, palliative medicine center, then bone marrow transplant facilities available at our institute, and kidney transplant facilities are also available. During the COVID era, we have treated around 48,000 plus patients. Other facilities which are available in our institute under the one roof are digital mammography, CT scan, MRI, EMG and EEG, newborn screening, prenatal screening, flow cytometry, plain clinic, digital PET scan, advanced histopathology, automated pathology, gene sequencing, pH manometry lab, and simulation lab. Different, IGRT systems, SBRT systems, gamma camera brachytherapy, and fish karyotyping, cyclotron, and best specific isotope facilities are available at the institute. Now, these are the picture of the digital mammography available at our institute. We can do the digital mammography guided biopsy with this machine. Next, I would like to present few data on the breast cancer. Breast cancer is most prevalent cancer among the women in India. Around 2.32 lakh new cases of the breast cancer are diagnosed in year 2025. Around 1 lakh breast cancer related deaths occur annually. Incidence for the breast cancer is rising with 1 in 28 lifetime risk for the Indian woman. Around 40 to 50% of the patient presenting at the advanced stages. It is significant public health challenge. How we can, solve this problem? Because most of the patients are presenting to us at a late stage. So we can start the screening at a right age and we can solve this problem. So now I would like to talk about the Nivaran Breast Clinic. It is a new and unique project started at the same hospital and university under the guidance of our founder chairman, Dr. Vinod Bhandari Sir, and Chancellor Ma'am, Dr. Mishra Bhandari Maam. Here we provide screening, prevention, and awareness regarding the breast cancer. We have a team of experts, surgeon, counselor, physiotherapist, radiologist, pathologist, oncologist, genetic analyst, molecular biologist, and other department working together. So the best treatment is provided to the patient. Free consultation is provided at our Nivaran Breast Clinic. We provide screening for the 40-year plus patient and also to the patients of any age group who present to us with the symptom of the breast cancer or who belong to the higher risk group. Different facility for screening and other investigations are available, which are provided at a discount rate at our Nivaran Breast Clinic. The Nivaran Breast Clinic, in addition to our Nivaran Breast Clinic, the Nivaran Pink Plus is added to this project in January 2024. Aim of this bus is to provide the screening, breast cancer screening for the urban as well as the rural population. Now, this is our team with the founder chairman and with the Nivaran bus. Now, a few words about the self-breast examination. Very easy, and as you can see in the pictures, you can perform the breast self-examination at home. Or Nivaran Breast Clinic, we increase awareness by conducting the seminar, lecture, and classes. Now, these are some of the pictures of the advertisement and photographs which are taken from the newspaper. Now, this is the camp conducted at the collector office by the Nivaran team. This is the district high court photos. Now, I would like to tell you about the data. So far, we have examined and screened around 42,000 patients under the Nivaran project. out of which around total number of the patient diagnosed with the breast cancer is 2,500. Total number of mammography performed under the Nivaran Breast Project is 13,000, and total number of patients who are diagnosed with benign breast disease under the Nivaran Project is 6,500. Total number of patients who have treated and now disease-free are 482. Now, this is our team. It includes the technicians, doctors, and nursing staff at various camps. You can see what is the goal of this Nivaran project. Why the Nivaran project was started by our founder chairman. First, we are planning to imply screening program in all districts of the Madhya Pradesh, and in the future we are planning to screen around 1 lakh plus patients. Get away home message: come and get yourself checked. And do not feel ashamed to do regular self-breast examination and yearly breast screening. Consult your doctor if you notice any changes in your breast, and let your neighbors and relatives know about our project. Thank you. And now we would like to play a short video which will give you insight of the Umido Wali Bus.
Dr. Vinod Bhandari Sir for the felicitation of Dr. Ashwini Sood. Dr. Ashwini Sood did his MBBS in 1985 from Indira Gandhi Medical College, then DRM in 1993 from the Radiation Medicine Center, DNB in 2000 with Sanjay Gandhi Institute of PG Sciences, Lucknow. With a work experience of 37 years and being a professor from PG at Chandigarh from 2021 to 2025, will be now joining us in the Department of Nuclear Medicine to be a part of SAIMS family. Thank you,
sir.
sir.
Yes. Now, I would like to invite Dr. Vinod Bhandari Sir for the distribution of certificates of appreciation and Dr. Shweta Singh Ma'am for the announcements.
Yes. I would request
Dr. Chaya Ma'am.
Dr. Chaya Ma'am.
We would like to thank our staff who is working doing the hard work and working with the dedication in the Umido Wali verse. So one by one, I will call the name. You kindly come to this stage and collect your certificates. So first, I would like to call the staff from the Nivaran Pink Bus. Dr. Mehraj Razvi from Physiotherapy Department. Nursing staff, Vandana Kaushal, Suhani Pawar and Sanju Dhangar. Helper, Manoj Susneria. The cervical cancer screening bus, Dr. Ruchika Chauhan. Then Sheetal Mandloi. Then technician Ram Sakle. Then oral cancer screening bus, Nisha Yadav, Anita Bairagi and Anil Panwar. And at last, I would like to call our assistant manager, Jiteshwari Gautam. So please collect.
ये अब जो दोनों आ रहे हैं, इन्होंने सबसे पहले बस में एंट्री की थी और ये सबसे ज्यादा मेमोग्राफी में सबसे ज्यादा मदद इनकी रही है, इसलिए स्पेशल इनको इनवाइट किया जाता है.
Jiteshwari Gautam, kindly collect. Yeah. Thank you, Honorable Chief Guest and respected family for helping us with the prize distribution.
Sir, you are requested on stage. Yes, sir. Yes, sir. Yes. Sir.
Now I would like
Ah, no, no, no.
now I would like to invite Dr. Vinod Bhandari Sir and Sana Afreen Ma'am to say.
Sir, after this. I would like to invite on stage. Yes.
चीफ मिनिस्टर वैसे इनॉग्रेट करने वाले थे अभी अपना डिपार्टमेंट, बट ही इज इन दिल्ली और वहां से वो किसी कैबिनेट मिनिस्टर के साथ बैठे हैं, तो वहां से ही क्लिक कर देंगे और उनका मैसेज भी अभी आएगा तो वो भी आपको पढ़ दें.
Thank you, sir. I would like to invite Dr. Vinod Bhandari Sir and Dr. Sana Afreen Ma'am to say a few words on starting the Department of Preventive Oncology, a new era.
This Nivaran card is a card which will provide a discount up to 50% for all the patients who are booked under Preventive Oncology department. And that will include many investigations, including the radio imaging and USG guided biopsies, image guided biopsies as well, and the other routine investigations as well. This is the introduction of a smartphone-based app for cervical cancer screening in a low-resource setting. So till now, what we are doing is we are doing liquid-based cytology, pap smears, and then the recording. But it takes time, the time lag, cut down the time lag. What the app is done is we take pictures of the cervices right from the examination table, and those are uploaded, and the AI gives you interpretation whether or not the cervix is healthy or there are some pre-malignant lesions that are harboring in the cervix. So this will help in the rural areas where the nursing staff will be screening the cervices, and even in our OPDs, we can use these AI-based apps for cervical cancer screening. So the solution was in developing a cervical cancer early detection through visual inspection and photo clicking by smartphones, which has Cervi Screen AI app. So we had a colposcope always, but then a colposcope is not available in the rural areas, and not everyone can afford having a colposcope. But having a just app in the mobile, it enables our smartphone to be used as a colposcope. So Okay, so the data of the patient information demographics will be uploaded in the app and the address and everything. And then the cervix will be screened after consent, and the patient will be counseled depending on the interpretation, and the HPV vaccination will be done. Thank you.
Thank you, ma'am. I would like to invite on stage Dr. Sana Afreen ma'am to say a few words on starting the Department of Preventive Oncology, a new era.
Good afternoon to one and all. I'm Dr. Sana Afreen from the Department of Community Medicine. I'll be briefing about the Preventive Oncology project. Why Preventive Oncology? Basically, we are aiming at early detection and prevention of cancers before symptoms appear at an early and treatable stage. So we'll be focusing on oral cancer, breast cancer, and cervical cancer. The objectives will be as follows. We have 5 clear objectives arranged in a continuum. First is awareness and education through health literacy, followed by active screening through on-field teams and camps, followed by referral and diagnosis to a hospital. This will be followed by patient treatment, and utilizing all the surveillance data, we will be tracking outcomes, which will help us in refining the protocols. We'll begin with IEC activities through pamphlets and talks in the community, followed by house-to-house surveys. And the output will be having eligible persons who will be who will require treatment based on the screening. The strength of this project is the mobile medical ecosystem. Basically, we have 3 buses, or rather, as we call it, the Umido Wali bus. It has an oral cancer unit, breast cancer unit, and cervical cancer unit. We'll be carrying out screening through these buses, and immediate counseling will be provided to the screened patients. The patients will then be referred to the hospital through referral slips, phone-based tracking, or patient navigation. And further diagnostic procedures will be done here. This is a flow chart showing the operational workflow. We'll also be integrating genetic testing here. This is the workflow that is showing the genetic testing. The patients will be screened. High-risk patients will be identified. Genetic counseling will be done, followed by genetic testing. And on the basis of that, preventive actions will be taken. The success of this project will be measured through multiple outcomes, including the coverage, staging, efficiency, sustainability, and our ultimate goal is to reduce cancer morbidity and mortality. Thank you.
Thank you so much, ma'am.
Now I would like to invite Dr. Vinod Bhandari Sir to come on stage for the inauguration of Nivaran card and give a details.
अभी आप लोगों के सामने निवारण कार्ड का इनॉग्रेशन डॉक्टर विनोद भंडारी सर ने किया, परंतु ये निवारण कार्ड है क्या, ये भी आप लोगों को मालूम होना चाहिए, तो उसके बारे में थोड़ा सा बताता हूं. निवारण कार्ड, it was introduced in the memory of our beloved teacher Dr. Rashmi Kulkarni Deshpande, who was actively involved in all activities of the institute despite her health issues. Dr. Rashmi was born in November 79 in Jalgaon, Maharashtra. Completed her MSc in biochemistry as a gold medalist in 2003 from North Maharashtra University, Jalgaon, and she was married to Dr. Ajit Deshpande in 2005. She joined Sri Aurobindo Institute of Medical Sciences in 2007 as a PhD scholar. She completed her PhD in medical biochemistry in February 2011 and joined the Department of Biochemistry as assistant professor and started working in forensic laboratory in 2013. She was diagnosed as a case of cancer of the breast in October 2013. She was operated and underwent treatment by radiotherapy, chemotherapy, targeted therapy at this center. She got recurrence after 5 years in 2018 and again underwent radiotherapy and other treatments. In 21, she was diagnosed with distant metastasis and also received treatment. She was always a smiling girl and talking every aspect of the disease and work very strongly, a very strong lady. We never saw her in depression and tension because of the disease. She was always busy in her work during the treatment also, and was also involved much in the family. She joined the NABH team in SAIMS in 2017. She was very active, brave, and enthusiastic with a strong willpower. Took the treatment without affecting the routine work. She continuously working for NABH team and taking classes of the undergraduates, teaching them every aspects. Even after getting brain metastasis, he used to take hospital rounds alone to improve working and also giving training of NABH and getting the work completed from the students as per the NABH norms, which are very hard. Because of her hard work along with the team, the hospital got NABH accreditation in the first go. She was also actively involved in the research work with the students. She did a PGA diploma in psychological counseling also in 2017 and started counseling of cancer patients as a cancer survivor herself. She was actively involved in our Nivaran clinic and attended all camps and counseled the patient. Although she was having the disease, but she was always going in the camps and giving her services. Because of her hard and dedicated work, she was felt state many times. We lost this brave lady on 12th September 2023, and in her memory, our founder chairman has started the Nivaran card to help the cancer patients. So what will be the benefits which will be achieved by the Nivaran card holders, the patients? And who will be the Nivaran card holders? All people diagnosed of cancer in our preventing campaign camp, whoso are diagnosed in our buses, which goes in village to village, will be the card holders. Card holders will get free checkup for early detection of cancer, 50% concession on the investigations, both during screening and treatment of cancer, and 50% concession on image-guided biopsies. This is a pink promise which the founder chairman has given for all card holders from this institute. Thank you.
Thank you, sir. Now, to end this prestigious ceremony, I would like to invite Dr. Deepika Malik, Associate Professor of Department of Radiation Oncology, to come on stage for the vote of thanks.
Good evening to all. As we conclude today's program on the occasion of World Cancer Day, myself, Dr. Deepika Malik from the Department of Radiation Oncology, on behalf of everyone involved in this program, would like to firstly thank all of you for being here. I thank especially our founder chairman, Dr. Vinod Bhandari Sir, for always being a visionary leader and facilitating not just this gathering, but also facilitating the all-encompassing world-class infrastructure for efficient cancer management here at SAIMS. I personally feel very satisfied and elated when I am able to treat a needful patient with SRS, SBRT, with minimal charges or under Ayushman. Just yesterday, we were able to start a patient on lattice therapy also. I also thank Dr. Mahak Bhandari Sir, Dr. Jyoti Bindal Maam, Dr. A.K. Mishra Sir, Dr. Vavre Sir, Dr. Anand Mishra Sir, and other senior faculty members. My heartfelt appreciation to all fellow departments and their heads, faculties, and residents for their active participation. Thank you to all the participating departments for updating us on their remarkable achievements. I take this opportunity to congratulate the newly established Department of Preventive Oncology. Lastly, following this year's theme, United by Unique, let us all carry forward the spirit of people-centered cancer care by learning from each other and continuing working together. Thank you. Thank you, ma'am. Now, before we end this ceremony, I would like everyone to kindly rise from your seats for the national anthem.
तव शुभ नामे जागे, तव शुभ आशीष मांगे, हमारे तब जय गाथा। जय गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
Thank you, everyone.